Chronic sternal wound infections are a source of major morbidity after cardiac surgery. Traditionally, a pectoralis major or rectus abdominis flap has been used for reconstruction. The omentum provides a mobile, well-vascularized tissue pedicle that can fill a large defect. With minimally invasive surgery, the omental flap, which can reach as high as the sternal notch, is an ideal source of tissue with less morbidity compared to the traditional flaps. Here, the omentum has been retracted into the upper abdomen to expose the avascular plane and its attachments to the transverse colon. This plane is used to separate the omentum from the colon. The right and left gastroepiploic arteries supply the omentum, and the flap can be based on either vessel. This involves transecting the omentum off the greater curvature of the stomach while preserving the chosen vessel. The flap shown here is based on the right gastroepiploic vessel. The omentum is extracted through a small epigastric incision and brought out to be used to fill the sternal wound defect shown. A skin graft will be used for external coverage. After trocar insertion with port placement as shown, the omentum is moved into the upper abdomen. Adhesions are taken down. The avascular plane is exposed between the omentum and the transverse colon. A harmonic scalpel is then used to dissect the omentum free of the colon. Bipolar shears or hook cautery can also be used, but caution must be taken in preventing the current from injuring the colon. The plane of dissection is usually quite obvious, but in states of inflammatory bowel disease or previous colitis, the plane might become obscured. As the dissection proceeds, care must be taken not to injure the right or left gastroepiploic artery, depending on which one is to be used for the flap's blood supply. Dissection is taken to the hepatic flexure on the right and the splenic flexure on the left. Care is taken not to use excessive tension on any adhesions that may cause bleeding along the splenic capsule. The omentum is then dissected off the greater curvature of the stomach. In this case, as in the preceding schematic, the left gastroepiploic artery is taken during the dissection, so the flap is based on the right gastroepiploic artery. Basing the flap on the left artery would allow the flap to reach even more proximally if distance was a concern. Care is taken not to injure the nearby splenic vessels during this dissection. The upper trocar site is enlarged slightly, and the omentum is then grasped and pulled out of the abdomen for use in the infected sternal wound, which will be debrided and then skin grafted by both cardiothoracic and plastic surgery. As you can see, this flap consists of quite a bit of omentum, which can fill a large defect. This is the appearance of the wound 2 weeks post-op and at 1 month post-op. Of note, the patient had return of her bowel function on her first post-operative day and was discharged home with minimal narcotic requirements for pain on her third post-operative day. She continues doing well, and the graft continues healing nicely.